leukemia is rare, and so this bears a is a challenge for the treating physicians to do the right thing. When we see a patient, usually the most important thing is actually to talk and look at a patient. So the clinical assessment. So this is what I was told in medical school: look at a patient, touch a patient, talk to a patient, right? And this is the basis for everything else, because people will tell you what's wrong with them, but you have to ask. You have to give them time to talk about it. So very unspecific things are night sweats, weight loss, fever. Then how do you do when you, for example, climb stairs? Do you have like shortness of breath? Do you feel like weak? Do you easily bruise? So these are things that make you aware of what is actually happening. And this is very important to do so, especially at early stage of disease onset. And then the next thing, and this is a really cheap way of looking at it, is to do a blood smear and a differential blood count. So differential blood count will tell you, like, do we have a high or a low? Both ways happens in leukemia. White blood cell count, is the patient anemic, meaning the hemoglobin levels are low, which would, for example, explain fatigue. Or what are the platelets? Are the platelets levels low? So this would also explain, for example, easy bruises. So when you look at a blood smear, and this is a very easy thing you can do it day and night, and can come at least to an initial diagnosis relatively quickly. On the left-hand side, you can see a healthy blood smear where you have red blood cells here. These are the red ones. Then you have neutrophils, which are granulocytes. These little purple dots are platelets. So this is how a normal one looks like. When you look at AML patients, ideally you see blasts, right? So here this is more prevalent, but sometimes you have to look even more, and it takes some time to look at blood smears to evaluate them properly. So these are these monomorphic cells. They all look the same. They don't look nice. They're not much. They're very immature. This is what we call blasts, immature leukemia cells. And the next thing is, and this is the least popular way of diagnosing leukemia, but it's the most important one, is actually doing a bone marrow aspiration, and in combination with a biopsy. Reason is, so this used to be even less popular than it is today, because how it was done initially was in your sternum. So you can imagine you're lying on your back, and somebody, I mean, in my case, I don't have a lot of hair, and I have a German accent, and like bending over and say, like, I'm gonna poke you in the sternum is not a nice thing to be. So this shifted towards doing it in your hip, and this is a very safe way, though it's still uncomfortable, way of getting a biopsy and getting an idea how the bone marrow looks like, and eventually getting a diagnosis. And usually what we take is a Yamashini needle, so we can do like an aspiration here, and we can also get a biopsy at the same time. So this is really good. And what you do is patient either lies on his or her side, or on his or her belly, and then you can access the upper right or left part of your hip bone, which is thick and basically it barely has any side effects except for like pain and a bruise. But it's very uncomfortable, I agree. But you can do a lot of things with what you get from there. And you can do, the easiest thing, of course, is microscopy. So you look at it, compare how does this bone marrow look like. You can do cytochemistry. For example, you can stain for myeloid markers just to get an idea, is this more like a myeloid or lymphoid disease? You can do flow cytometry, and I will explain this later, but this will give us, it's also like a relatively quick method to give us an idea about, is this a lymphoid or myeloid disease? Because this can be sometimes tricky, because acute lymphoblastic or acute myeloid leukemia can look the same. Then eventually you will do molecular genetics. This takes longer, this takes days, and cytogenetics, which can sometimes take longer than a week to get those. But this will, all these information you gather from these investigations, you will help you to eventually figure out what kind of leukemia subtype it is. That's why this is really important to do. This, for example, is a typical example of cytogenetics, and these things here are human chromosomes. Here is a duplicates. Usually we have one. This is chromosome 1. This is chromosome 7, 8, 21, and these are the gender-specific chromosomes, the Y and the X chromosomes. So this is a male karyotype. That's how we call it. So what we're looking for is, are pieces missing, and are there gains? So you can see, and this is an AML patient with a translocation 821. And here you can see at chromosome 8, there's a piece missing, and then you're like, oh God, where's this piece here? And I've done this myself and during my training, and it's a major pain in the butt actually to look at these karyotypes. It takes a lot of art and a lot of knowledge to do so. And you can see that this part here is glued to chromosome 21. And based on that, we conclude this is a translocation 821. And this is important because it will tell us, okay, this is a favorable risk group. So this patient might get a different treatment than somebody who is in the adverse risk group. And even more modern is to combine, we sequence the genome of these leukemia cells. Basically, this is something most centers do. They either send it off to a place that's specialized in doing so, or they do it themselves. And this is another piece of information about the genetics of the disease. And this combining molecular information with cytogenetics eventually will result in these AML subtypes. And we are able to tell you exactly, is this in 821 translocation? We say like, yes, but now we have to know, okay, where is the exact mutation? Is it a subtype of this translocation? I mean, you can see that, for example, APL, which is considered as APL with a typical 1517 translocation, has different subtypes. Or like NPM1 mutated leukemias, which usually do not have a specific translocation, you can see that you have like 8 different subtypes. And this will even increase the better our diagnostics develop over time. Within the next few slides, I want to focus on APL, on T1517, because I think it's a very good example how research can change the outcome of acute myeloid leukemia treatment. Initially, this disease was described in 1957 by Mr. Dr. Hillstadt, and he reported 3 cases of AML patients